Thank you very much, everybody. That was a great talk from Bo. I think everybody's worst nightmare is perforation, especially in certain places. Chris White, could you just tell us a little bit about what your worst nightmare is? Where do you worry about perforations the most, and what do you do about it?
The worst place to perforate, Kenny, as you well know, is the external iliac. I mean, that is a lethal perforation. Um, we always have covered stent grafts and balloon tamponade available. Interestingly, structural heart disease has helped us become much better at managing these disaster complications. We used to have them very rarely with peripheral angioplasty, but the structural guys have them on a daily basis. So we've gotten pretty good at fixing these. So, but I do think the external iliac is the place that scares the pants
Yeah.
off.
Well, that's what I thought you were going to say. And so maybe Shirley, maybe you could comment on this. Uh, are there any external iliacs, or do you routinely use in certain instances covered stent up front? For example, when you have exophytic calcium, you think might or cause spicules to puncture and so on. I mean, there's certain things that are predictors up front that you look at.
Yeah, so Subash and I talk about this pretty frequently, but I think the time to address this is actually well before you're going to do your intervention requiring, whatever you're going to need to do to the external iliac. So you do see this a fair amount in the structural heart cases where it's, like a big TAVR device trying to get through a very small iliac. And, it's always uncomfortable to think about how you're going to deal with the ruptured iliac afterwards. But sometimes if you can think about maybe doing an endoconduit beforehand and putting in this, the covered stent beforehand and having a decent access, that can sort of spare you from a urgent use of a covered stent afterwards if the iliac ruptures afterwards. So that's what oftentimes we'll consider. But then, sometimes we don't have the foresight to think of that. And then, if it's a large bore access, what we'll do is we'll have the sheath and a dilator ready to put back up there if the iliac ruptures on the way out, because that's when it will rupture, is when you're taking the sheath out. And then usually we're thinking about this as we're going up and getting the access, I'll find the ICAS or the VIA bonds so that if there's a rupture at the end, we can use them. And the other thing that we've started using sometimes is the expandable sheath, which I think works pretty well in some cases. You kind of have to pick the cases that it'll work in, but in the cases we've used them, it's worked pretty well.
So that's good. I mean, you're talking mostly about structural cases where the classic iliac on a stick happens. We've seen that. But, Kumar, what about for obstructive disease when you have a heavily calcified obstructive lesion? Or chronic iliac occlusion? Do you have a different approach to that? Do you think those are more likely to rupture? So 2 questions.
Yeah, I mean, I think in those cases, first of all, great cases to show. It's fun to watch somebody else's complications, but seeing heavy calcified, especially obstructed, heavy diseased iliac, external and common, for me, it's usually covered stent without compromising the internal for both of those in those situations. If I just have heavy occlusive calcified common, then I'll go covered there and I'll go bare metal on the external if I feel comfortable. But if your inkling is that this is a little treacherous, there's nothing wrong with going covered just to be on the safe side. But I agree with the comments about don't start a case without having balloons and covered stents literally within a minute's reach.
Yeah, that's good. So Eric, there's a lot of times when you dilate, by the way, the total occlusion scenario is a chronic external iliac occlusion. I would just make the comment, you don't want to over dilate them. You want to sequentially dilate them. And those you'll lose patients with. You will lose patients. Eric, what about in the SFA? We often dilate and then you see this smudging, dissection, and you see quick venous filling and you don't know what to do about it. You figure, well, there must have been a rupture or something. What do you think about that? What is your approach to that situation?
Yeah, great question. Yeah, it's first I want to make one more comment. Something I've grown kind of a little bit more comfortable with in the iliacs is using shockwave for some of the really complex calcific ones, because the key there is you could take a 7mm shockwave balloon up at 4 ATS and let it do its work instead of serially trying to really pressurize high pressure balloon inflations to get the result that you want before you stent. So that's been a nice kind of adjunct for me in the iliacs. For the SFA, it's always perplexing. When you perf, when you've created fistula, what's troublesome to the patient. I mean, it's not infrequent that we develop some either wire or cause perf or AV fistula that you need to balloon tamponade, but most of these do not cause substantial compromise if you are paying attention to them and you do prolonged balloon inflation. So, very infrequently do I need to put a cover stent in for a fistula. The key is really identifying the location of the fistula, and also identifying if it is a perforation, which is usually pretty clear, especially as they won't wash out. The other thing I always think about whenever I have a perf in any part of the body is, can I get manual compression on there? So often I will have a picture with my hands in there, not my fellows, my hands, to make sure that I could get hemostasis. And often, just as Bo did in the other one, is if it's on the extremity, you can try to put a blood pressure cuff on and take angio's with that on and off. And I think that's a key thing to think about when you're stuck in a moment like that.
So June, let me ask you, are there other considerations when you have a perforation? I agree having the stents, covered stents around and so on, but there's so many things you have to think of all at once. Maybe you could sort of list through, okay, patients, you dilate an iliac artery, it looks like, oh my God, you deflate it and the patient suddenly has horrible pain. What is going through your mind and what do you ask for right up? What do you bark out orders? What are those orders you bark out?
So with patients that you think are actually at risk of iliac perforation as you're doing the balloon angioplasty, I think the most important thing is you can actually do a test shot even before you remove the balloon. So don't take the balloon off the wire is the first and most important thing, because it's just right there. You can balloon tamponade it while you're calling for your cover stent and having the nurses administer fluids. Obviously, having surgical backup is important, and you should be aware of the surgeons in the environment that you're practicing in so that they can come and help you quickly. I think those are the most important things to understand. Obviously, having cover stents in your practice is important. The other important issue with cover stents is make sure that you do oversize the cover stents, because you do want to seal them at the edges so that you don't get bleed through around them.
I think so. Good. We'll just finish with that. But so you made comments. Volume. You need to have access for large volume. You need to get blood. You need to call for surgical backup, even if you're not even 100% sure you'll need it. Just get them there because you're colleagues and we work together. And yes, get everybody focused on the team. Leave the balloon across the lesion. Get pressure. Get additional help in. I always call for my colleagues from the other rooms and get people there, because there are things you might not think of.
This is Subhash. I want to add one thing, hopefully you will appreciate. I mean, I think that the compatibility of the guide wire to think of is also very important. And I think I've seen those delays when someone tries to load a over 8 compatible cover stent over a 035 wire and have not done the exchange. And I think that can be very, very interesting and important, and those kits should be available at hand.
Yeah, sometimes you need to get other access to deliver this, have the balloon inflated. You don't want to deflate that balloon because it's a fire drill trying to do the exchange and get it out while the patient's bleeding out. So you get another access site and deliver your definitive therapy through that other access site.